Behind Indiana's jail security doors, the daily routine has become a high-stakes exercise in emergency triage. These facilities operate as frontline medical wards, responsible for a population arriving with acute injuries and long-term untreated conditions. By law, Indiana County jails must provide comprehensive medical and mental health care. For the staff on duty, this means managing everything from active infections to severe substance use disorders as a core part of their daily operations. Effective medicine relies on a continuity of care loop. Accessible patient history informs active treatment, which flows into consistent follow-up care. But jails are the opposite. Rapid turnover means people move through custody so quickly, it severs connections between past records and future treatment. When a stable healthcare model is forced into a facility defined by transience and disruption, the chain of care begins to fracture before the first dose of medication is even administered. The first break happens at booking. Inmates rarely arrive with medical files or insurance data, leaving intake staff to operate in a total information blackout. This creates an immediate triage burden. Staff must identify chronic conditions like diabetes or hypertension and verify active prescriptions within hours, often with no external records to confirm what the patient is telling them. The risk is highest for those entering with severe substance use disorders. For these individuals, without immediate monitoring for withdrawal, the first 48 hours of custody can become a medically fragile window. Even a 12-hour delay in verifying a doctor's order can allow a manageable chronic condition to escalate into a medical emergency. Without verified data at the moment of booking, this intake blind spot becomes a primary point of failure, where medical histories are lost and vulnerabilities are highest. Beyond the intake desk, the challenge moves to logistics. While jails have basic clinics, serious health needs require coordination with outside specialists and regional hospitals. This creates an enormous drain on local resources. Rural counties must arrange secure transport and pull officers off the floor as medical escorts. The financial pressure is heavy, as smaller budgets struggle to absorb high inpatient hospital care costs. Indiana tries to bridge this gap through state-level policy. Programs like presumptive eligibility for inmates allow hospitals to temporarily enroll eligible inmates into Medicaid to cover authorized inpatient services. While this provides vital funding, it also adds a dense layer of administrative work. Staff must navigate complex application processes and state reimbursement rules on top of their security duties. It forces county sheriffs to function as healthcare administrators, managing a complex medical network their facilities were never designed to support. The mental health crisis puts even more pressure on the system. Because the number of inmates in psychiatric crisis vastly exceeds the availability of clinicians, behavioral health systems inside jails are buckling. Recent reporting from the state's Correctional Ombudsman highlights the strain, citing recurring complaints about access delays and missing psychiatric medications across Indiana facilities. For those with severe mental illness, jail becomes part of a revolving door, a cycle between short-term holding cells, hospital emergency rooms, and the city streets, without any stable follow-up care to break the pattern. Due to these resource gaps, mental health care in the jail setting is often reduced to crisis intervention rather than long-term clinical stabilization. The final break in the chain happens at the exit. When an individual finishes their sentence or posts bail, they step out of the facility and back into the community. This moment is the re-entry cliff. It occurs when a person is released without their necessary medications, without reactivated insurance, and without a scheduled follow-up appointment with a doctor. Releasing someone in this state leads to immediate consequences: acute medical emergencies, rapid relapse, and the eventual cycle of rearrest. Solving this requires more than just better jail clinics. It requires an interconnected system of fast intake screening, streamlined Medicaid access, and rigorous discharge planning to keep the loop closed. Indiana's jail healthcare challenge isn't just a localized operational problem. It is a critical vulnerability in the state's broader public health infrastructure.